The image shown here depicts what occurs when a person is infected with HIV, something I will review in more detail in a later slide. HIV stands for Human Immunodeficiency Virus. Human because it's transmitted from human to human, and immunodeficiency because the virus actually attacks cells in the immune system and destroys the immune system of the host. HIV is a retrovirus. This means that its genetic material is RNA, and it has enzymes that actually convert the double-stranded RNA into DNA. HIV targets specific cells, specifically the CD4 cells, which are responsible for helping fight off infections in the body. To give you a little bit of background, let me briefly take you back to the 1980s when the MMWR report was published by the CDC. People sometimes say that HIV started in the 1980s in the United States, but in fact, this was just when people first became aware of HIV, and it was when it officially became recognized as a new health condition. In 1981, a few cases of rare diseases were being reported amongst gay men in New York and California, such as a lung infection called PCP. No one knew why this opportunistic infection, which does not normally affect or infect healthy individuals, were spreading. But they concluded that there must be an infection or an infectious disease causing them. At first, this disease was called all sorts of names relating to the word gay, not necessarily the most PC thing. It wasn't until around the mid-1982 that scientists realized that the disease was also spreading amongst other populations, such as hemophiliacs and heroin users. By September of that year, the disease was finally named AIDS. It was only in 1983 that the virus was isolated and identified by researchers. Originally called lymphadenopathy-associated virus, the virus was confirmed as the cause of AIDS when scientists working at the USA National Cancer Institute isolated the same virus and called it HTLV, later acknowledged to be the same thing as lymphadenopathy-associated virus. Here's another image showing what we previously discussed for those who are visual learners. On the left, you will notice a tube of blood of an uninfected person. Here it shows infection, and here is what occurs with HIV infection. As you can see, once a patient progresses to AIDS, they essentially do not have any CD4 cells and essentially no immune function to protect them from other infections. This slide here shows the complications of HIV and AIDS. HIV infection, of course, weakens your immune system, making you much more likely to develop many infections and certain types of cancers. Infections common to HIV and AIDS includes PJP, candidiasis or thrush, CMV, which is a viral infection, TB or tuberculosis, and cryptococcal meningitis. There's also the chance that various invasive cancers can be present in those with HIV. Next, we'll be discussing transmission, or how HIV is spread from one person to another. So transmission is actually directly related to the viral load, or known as the inoculum. You are more likely to get HIV if a person has a high viral load and is spreading it to you. So the larger the inoculum, the higher the risk. If a person who is HIV positive and has remained on antiretroviral therapy with a non-detectable viral load, meaning that a blood test is not able to detect how much virus is in their body, it is very unlikely or very low risk of transmitting HIV at that point. There are several ways that HIV is passed from one person to another. In the United States, HIV is spread mainly by having anal or vaginal sex with someone who has HIV without proper use of a condom or without taking medications to prevent HIV. Sharing needles or syringes, rinse water, or other equipment used to prepare drugs for injections with someone who has HIV is another way of transmission. Less commonly, HIV may be spread from mother to child during pregnancy, birth, or breastfeeding, although risk can be high if a mother is living with HIV and is not currently taking medication. And also, another less common way is being stuck with an HIV-contaminated needle or other sharp object. This risk is mainly for healthcare workers. In extremely rare cases, HIV has been transmitted by oral sex. Which bodily fluids can contain HIV? Semen, vaginal or anal fluids, breast milk, and blood from a person who has HIV can actually transmit HIV. Saliva, sweat, and tears cannot transmit HIV and does not have HIV contained in them. These fluids must come in contact with the mucous membrane or any damaged tissue, or be directly injected into the bloodstream from a needle or syringe for transmission to occur. Mucous membranes are generally found inside the rectum, vagina, penis, and mouth. To the right, I've included an image of the estimated per act probability of acquiring HIV from an infected source published by the CDC. This will correlate with the discussion we just had in regard to all the modes of transmission and their related risks. As you can see, blood transfusions will have the highest risk. And out of all the sexual risks, anoreceptive intercourse has the highest risk.
Next, we will move on to prevention. On this slide, I will be discussing medications or prophylaxis, also known as preventative medications, to help prevent the transmission. There are two different therapies that are currently approved for prophylaxis or preventative medications. These medications are included in the new legislation that allows for pharmacists to dispense these medications without a prescription. First, we have PrEP, also known as pre-exposure prophylaxis. Two currently FDA-approved medications for use for PrEP include Truvada or Descovy. These medications are taken daily to help reduce the risk of HIV and can only be taken in patients who have a confirmed negative HIV test, as these regimens are not active against HIV if a person has a positive HIV test. Generally, they are recommended for those who have high risk, such as high-risk sexual behaviors, as having multiple partners and reporting inconsistent condom use. And when taken consistently and appropriately, PrEP is 90% effective. Alternatively, we have post-exposure prophylaxis or post-exposure medications to prevent transmission, known as PEP. This is to help decrease the risk of HIV transmission after exposure. A good example of PEP use would be an occupational exposure. For me as a healthcare provider, if I accidentally get a needle stick from a patient who I just recently immunized, it might warrant me to start on PEP therapy to ensure that I don't get HIV, especially if the HIV status of my patient is unknown. It must be taken within 72 hours of the initial exposure and then continued until it can confirm that either the patient is HIV negative or until I complete therapy and it's confirmed that I do not have HIV. There are other modes of prevention, especially in preventing mother-to-baby transmission. The most important thing with perinatal transmission prevention is ensuring that the mother is on HIV therapy and is well controlled. There is also treatment for baby or infant once the infant is born. And it is important to avoid breastfeeding. On the previous slide, that breast milk can contain HIV and can pass HIV along to baby. On this next slide, I would like to discuss prevention strategies that do not involve HIV prevention medications. Today, there are more tools than ever available to prevent HIV. You can use strategies such as abstinence by not having sex at all, which is actually the only 100% effective way of preventing HIV. Limiting the number of sexual partners one has, or making sure to use condoms every single time you're engaging in sexual activity. I recognize that abstinence may not be the most ideal for a lot of different people, so it's important to make sure that education is provided to encourage patients to practice safe sexual behaviors. If concerns for risk of HIV transmission, it's important that condoms are used every time sexual intercourse is going to occur, and that condoms are used the right way. There are male condoms and female condoms that are available. The correct way to use a male condom is to make sure that you are using it every time you are having sex. Condoms are to be put on prior to sex, and it is important that the package and the labels are checked for any expiration dates, and that the package is inspected to make sure that there are no tears or defects in the actual condom. Condoms are to be stored in a cool and dry place. Lubrication, especially water-based or silicone-based, can be used to also prevent breakage of the condoms and prevent slipping. It is not recommended that oil-based lubricants are used. For example, Vaseline, any type of mineral or massage oils or body lotions, as these can weaken latex condoms and cause them to break. As for patients and injection drug use, it's always important to advise individuals to not share any injection equipment. However, this may be difficult for those who are living on the streets and do not have proper education. It is good to always know where the local needle exchange program is. These are generally held by the county, where individuals are able to bring in their used and dirty needles to exchange them for new ones. Lastly, treatment as prevention is another strategy to prevent HIV transmission. In an individual who is HIV positive and remains on antiretroviral therapy with an undetectable viral load, meaning that the virus amount in their blood is so low that it remains undetectable through a blood draw, that they are not likely to transmit HIV onto another patient, although they are positive. I've spent some time talking about HIV infection itself, transmission, and prevention. Now we'll move along to treatment, which is the most exciting part. Currently, there is no cure for HIV. However, as I previously discussed, current ARVs do a great job of suppressing viral replication and thereby preventing immune system dysfunction. By suppressing viral replication, we're not getting further infection of the HIV into new CD4 cells. Therefore, we allow for CD4 count to remain high and thereby preserving immune function in a patient who is infected. Those who are tested positive for HIV must start antiretroviral therapy immediately and remain on therapy lifelong. It's important to assess a patient's readiness to commit to lifelong therapy, because as you'll see in the next slide, non-adherence or non-commitment to therapy can lead to resistance, and resistance can result in limited amount of treatment availability for a patient with HIV. Being on ARVs will only prevent infection of susceptible cells, but it does not eradicate a virus from a cell that already harbors integrated proviral DNA. Usually, successful treatment with ARV will contain 3 active ingredients. All recommended antiretroviral treatments will contain a backbone that has 2 NRTIs, or 2 nucleoside or nucleotide reverse transcriptase inhibitors, and will contain 1 core agent. These core agents include integrase strand transfer inhibitors, also known as INSTIs, protease inhibitors, also known as PIs, or non-nucleoside reverse transcriptase inhibitors, or NNRTIs. It's important to have 3 active ingredients to ensure efficacy and to prevent the development of resistance. There are also additional agents that have been approved for the treatment of HIV. However, these are not commonly used and are not first-line recommended agents at this time. These agents include an entry inhibitor and a fusion inhibitor. It's important to assess patients to determine any barriers they have to successful treatment. Certain barriers to successful treatment include development of resistance, potential side effects or adverse reactions to medications, potential drug-drug interactions between ARVs and other medications that may reduce the efficacy of ARVs. And, as I've mentioned over and over again, non-adherence to ARVs or medications used for HIV. Besides treatment, mutations and resistance is another very interesting topic about HIV. Mutations are caused by the rapidly replicating HIV viruses. They typically produce billions of virions daily in a person who is HIV positive and not currently on any ARVs. As I've mentioned previously and over again, noncompliance or non-adherence to therapy increases the risk of mutations. At the reverse transcriptase step of HIV replication, mutations can occur at a high rate because the HIV reverse transcriptase enzyme fails to correct any erroneously incorporated nucleotides. These changes in nucleotide sequences generate amino acid substitutions during translation, which can alter the function of enzymes such as reverse transcriptase, protease, or integrase, as well as change the binding proteins and the envelope proteins of the HIV, which can create resistance to the different classes of medications. If a person with HIV takes antiretroviral therapy with good adherence and maintains suppressed viral load, there's insufficient HIV replication for these mutations to occur. With inadequate adherence or poor compliance to medications, those viral strains that develop mutations with resistance to antiretroviral regimens will have fitness and, as a result, will be more likely to replicate and outnumber the other HIV virus that was previously responding to medication. Different medications will have different barriers to resistance, which refers to the number of genetic mutations required to develop resistance. For example, ARVs with high barrier are less likely to develop resistance. Another thing to be concerned about is cross-resistance. So when a patient is diagnosed with HIV, it is likely that they will do some genetic testing and resistance testing to make sure that they have not acquired a virus that has predisposed resistance. There are certain classes of medications that have cross-resistance, for example, efavirenz and nevirapine, which are both NNRTIs. In the presence of a K103N, you are unable to use both of those medications. Having this specific mutation confers cross-resistance, which means it affects drugs within the same class. Now we can see why mutations in resistance can become a potential problem for patients, because not only will they become resistant to one medication, but may become resistant to a whole class of medications. Currently, integrase strand transfer inhibitors, or INSTIs, have the highest genetic barrier to resistance. Additionally, these medications are well tolerated, which is why they are currently recommended as the first-line agent in combination with a 2-NRTI backbone as initial therapy in HIV-positive patients. Here is a summary of the medication classes that are used in HIV. As I previously mentioned, fusion and entry inhibitors are not commonly used. However, both are still FDA approved for the treatment of HIV. The really important oral agents that we'll be going over today are medications that are in each of these following classes. NRTIs, which are the nucleotide or nucleoside reverse transcriptase inhibitors. Then we have NNRTIs, which are non-nucleoside reverse transcriptase inhibitors. Of note, NRTIs and NNRTIs both target the same enzyme. We also have protease inhibitors, as well as INSTIs or integrase strand transfer inhibitors.